Hi there. I'm Dr. Hailey Kobernick, and welcome to another episode of the Therapy Should Work podcast. We're going to be spending a bunch of weeks talking about some foundational concepts for the topic of therapy should work and where the project has taken us until now. And then we're going to, Mirza Shem, start a series focused on a specific topic. Save that as a surprise, what the topic's going to be. But that will be including interviews with special guests who are experts and leaders in the field. So I'm excited for that coming down the pipeline. But I did want to spend a bunch of episodes explaining some important concepts. So the topic I wanted to focus on today is where the field is getting kind of lost from my perspective for what it's worth. I think in other areas of healthcare, there's a more direct pipeline from the scientists who are doing the research that informs the providers and how the providers consume that information. That's definitely not perfect in any field. A well-known relevant piece of information, there's something called the 10-year research to practice gap, which is that there's generally, like across healthcare, there's a 10-year gap between where the research is holding and what the providers are implementing. So that exists. That's real. Specifically in mental health care, I think there's an even wider gap for different reasons. And I think for mental health care, there's an even wider gap for even more specific reasons. So, in mental health care in general, there is a research to practice gap, just like there is in any field. But I think that in psychological science, there's maybe more of a risk because the way we implement our treatments is through a person more than through a pill or through a procedure. I think it's easier for things to get lost and for there to be more provider bias, I'll say like that. I think that there's just more room for us to be less precise in our procedures because we're not dispensing a pill and we're not performing a specific procedure with a specific set of instructions and maneuvers that have to be completed maybe in the way that there is in other areas of healthcare, although obviously there's nuance in any field. I think particularly in mental health care, obviously we're using the therapist as the tool for implementing the technique much more so than any other area of healthcare. And because that's the case, there's just a lot more room for the provider's bias in how to implement the procedure or for drift to happen, drift from the intended model, let's say. That's also another critique that I think is important to bear in mind is that while we do have today specific techniques for how to implement different treatment models for different problems. Let's say, for example, it's a pretty known, I don't know how known, but it's pretty known that exposure is the treatment of choice for OCD, let's say, or for anxiety-based issues. And that said, there are specific protocols of how to go about doing that. And the protocol is less important in creating change than the mechanism of exposure. What I mean by that is that we know exposure is important as a key component to treatment for specific issues. But what we don't necessarily know is that if you follow this 12 session protocol to do exposure, that it's going to be more effective than this other 12 session protocol that does exposure. There might be some data on that, but I think that's pretty known that it's not about the protocol per se as much as the mechanism. So just to explain that one more time in case that's not clear, because I do think I'm using some terms that might not be clear. What we know in psychological science is that there are certain mechanisms that are very important or critical to psychological change. What we don't know is that specific protocols are necessary. But the way we do research, and this is just a problem in doing research, and this is similar, I think, in other areas. I'll share a cute example in a second. So because we have to test protocols, we've developed protocols, and then we know the protocols work. We don't necessarily focus in research on mechanisms, although that is, I think, generally where the field is going right now. I think the field is looking very critically at mechanisms over protocols. But over the last, let's say, 2 decades, or maybe even longer, maybe say the last 3 decades, there's been a major focus on protocol-based treatments because that's what we can study most easily. An acute example of this is I was asked many years ago to write a mindfulness curriculum for a school where the principal was interested in mindfulness personally, like he just was interested in mindfulness, and he was sharing it with the students. And then somebody, I don't remember, had raised the issue of, is mindfulness Buddhist? Is this hashkafically okay that we're doing this? We should run it by the Rav that we asked Shilas to. The Rav was asked, and the Rav said, I can't possibly, I don't know what you're talking about. I mean, I understand theoretically the concept of paying attention on purpose to the present moment. That sounds good, but I don't know exactly what you're doing. And so I need some kind of curriculum to look at. And that's when I had been asked to write a curriculum, and then the Rav had something to look at. And I think that that speaks to that exact problem, right? So a Rav is saying, I can't paskin without something to look at. It's like, what's the actual thing that's happening here? And psychological scientists are saying the same issue of, we can't test a mechanism, we have to test a model. I mean, we could test a mechanism. I think that's, again, where things are headed. But when people were developing treatment models, there was a focus on protocol over mechanism, which I'm saying, so it makes sense how we ended up in this problem. So how we end up in the problem is valid, and it's still a problem that we have a focus on protocols over mechanisms per se. So as I was saying, there's particular bias when it comes to implementation because we're using the therapist as the implementer as opposed to a machine or even a set of instructions. So that's where we went on this detour. Protocols are maybe more of a set of instructions. But even within protocols, there's so much variability and there's so much principle or protocol or function over form. I think that goes on more so than in a surgical procedure or any kind of other procedure that needs to be done in medical care. So I think that that's something that's a nuance in psychology or in mental health care that makes it more difficult or more easy to have provider bias or drift. We call drift is like drifting from an intended model. And the problem with that is that then we have a lot of nuance and outcomes. So obviously there's human variability. Humans are complex. And this would be the same in medical care. We're going to have human variability in response to any medical intervention. And so how much more so in the complexity of the human mind and how complex humans are, and human experience is so varied. And so there are just way too many variables to account for in terms of ensuring particular outcomes with every single intervention. And then what I'm adding is another layer on top of this is the provider drift that's so likely with interventions that are so heavily reliant on the therapist's style, mood that day, level of energy, what time in the day the therapist is seeing the client, any biases that sneak in that relate to that client's demographics or background or the nature of their problems or how those problems present themselves. So many things that can sneak in and affect how a therapist provides the intervention that's so much more complex than the intervention itself. So you can't just control for and say, okay, we're going to give 100 people with OCD exposure therapy and 100% of them are going to get better. That's like so so not what's happening in the real world and so subject to so much variability. So I think that's kind of where we ended up with, I mean, that's a general idea of where we ended up with the problems that we're facing today in terms of the distance between psychological science and what's happening in mental health care on the ground in general. I think in the frum community, there's plenty of nuance as to how that plays out for people seeking mental health care within the community. For example, 30 years ago, there weren't that many frum therapists, and so you had to seek help outside of the community. And today there are so many frum therapists, there's really no reason to need to seek therapy outside of the frum community. So that's going to just change and affect how we seek mental health care today. I think a very significant, and I hope I'm going to say this the right way, I think a very significant factor in the frum community is the fact that because as a population, these are my massive assumptions, so just take it with a grain of salt. We are hardworking, we are caring and sensitive and empathic. We care about Klal Yisrael deeply. We want people to feel good. We care about people. And we also want to have good careers that can be mefarnei our families. And we want to not spend a lot of our adult life in higher education because we want to move on to building our families, raising our families, and being mefarnei them. So that, I think, is just a reality that we're dealing with on a societal level that impacts all kinds of things. But one area I think it impacts is that there's been a major uptick in the number of frum therapists and people pursuing degrees in mental health care. And I think as opposed to, and this is my assumption, I have no numbers on this, is totally my observation, it could be completely incorrect, that as opposed to in general society where there's maybe more of a breakdown of different levels of training that impacts how the general public experiences therapy, I think in the frum mental health world, there are many more people trained in the social work degree specifically. And the social work degree is one type of mental health degree that leads to somebody becoming a therapist. There are all different kinds of other degrees that also lead to somebody becoming a therapist. And let's also consider, I think, the fact that outside of America, there's generally, depending on the place, but outside of America, there's generally less structure around requiring a degree in licensure. So there might be even less than this going on in many, maybe like coaches or people saying that they're therapists without a specific degree. So that even changes even more vastly outside of America or whatever, the United States specifically. And that training is not necessarily going to lead to a strong connection between science and what we do in therapy. So this is a generalization. This is not on a specific therapist at all. But if the majority of therapists serving the frum community are either social workers or either trained in the degree of social work or are not trained at the graduate level, let's say, then the disconnect, so this is again, be very clear what I'm saying, then the disconnect between the science and what's happening in the therapy room is going to be even greater than in the general public. So that's my theory as to why in the general world there's a disconnect, and why in the frum community I think there's an even stronger disconnect for this reason. And this is significant because then we're just seeing so much more variability in what people are receiving in treatment. And I think this leads to greater mistrust of therapy because we're going to have even more varied outcomes than a psych lab is going to have. And of course, that's always going to be the case because lab world versus real world is going to we're going to have more variability in the real world. But I think we're having even more variability with such a strong disconnect between the science and the practitioners. And so that is my thesis. That's my theory as to how we have gotten to the problems that we have. I think I will cap it here for this episode, to be continued. And I'm excited to continue this conversation.